Sex Addiction. My name is Nakusa Moreland, and also my partner is Mackenzie Gallo.
So the first thing that we kind of came up with was questions. The book had similar questions, and so does Martha's PowerPoint. But essentially, we're just wondering, before learning anything about this topic from this class, how would you respond to a loved one who reported that they struggle with sex addiction? And would your response change if if it were your partner compared to like a sibling or a friend? And would your response be the same or different after this class?
So next we're going into the definition of sex addiction. Sex addiction is described as a compulsive need to perform sexual acts. This needs to be distinguished from OCD, and it also needs to be distinguished from high sex drive. OCD, although has thoughts that often have sexual content, they generally occur with negative mood without accompanying sexual arousal, and the negative mood associated with OCD often leads to a decline in sexual arousal ability. So, furthermore, these individuals with OCD score high on measures of harm avoidance, in contrast to sex addicts who score high measures of risk taking. It's believed that a person with sex addiction will seek out multiple sex partners, though this in itself is not necessarily a sign of the disorder. Some report that it may manifest itself as a compulsive need to masturbate, view pornography, or to be in sexually stimulating situations. A person with sex addiction may significantly alter their life and activities in order to perform sexual acts multiple times a day and are reportedly unable to control their behavior despite severe negative consequences.
So, just to add on to that, sex addiction does not have to necessarily include a partner. It can include some impulsive need to masturbate, watching pornography, but again, that needs to be distinguished from pornography addiction. It can include phone sex, frequent visits to strip clubs, cyber sex, or be in generally sexually stimulating situations.
So, porn addiction versus sex addiction. So, pornography rarely depicts scenarios that accurately depict real life scenarios. A common problem is that people who watch porn, especially men, may develop unnaturally high expectations for their sexual experiences, and they may begin to see their partners and their sex lives as inadequate. As a result, people with a porn addiction often develop difficulties engaging in normal sexual encounters. Porn addiction is also known to be similar to a video game addiction. These addicts often struggle with sexual performance. They may typically like a steady relationship. It's known that porn addiction is on the rise, and there are increased risks with sex addiction as well. People with porn addiction often turn to porn in the first place because of a desire or a lack of intimate relationship. A significant number of websites, around 12% in a recent estimate, are porn sites, and many are free to access. As a result, the prevalence of online porn viewing and porn addiction have risen as well. The most recent statistics show that today between 5 and 8% of the adult population of the United States struggle with porn addiction or problematic pornography use. Watching porn can become a problem if seeking porn involving children, adolescents, or a non-consensual adult. Sex or porn addiction can be devastating to both the person with it and the people close to them, and can cause issues in the individual's everyday life.
So, according to the ICD-11, compulsive sexual behavior disorder has been added as an impulse control disorder. It is characterized by the following: persistent inability to control intense, repetitive sexual impulses or urges. It manifests over an extended period, so 6 months plus, and it can negatively affect family, social, educational, and our occupational areas of functioning, and also includes repetitive sexual activities may become an essential focus of their life to the point they neglect their health and personal care responsibilities or interests.
So, like it was mentioned, the DSM 5 does not currently recognize sexual addiction as a mental health disorder. Professionals typically use other specified sexual dysfunction in its place. Though they have reason to use this label, it is inaccurate because sexual addiction is not the same as sexual dysfunction. From what I've read, the most accurate label would be other specified disruptive impulse control disorder.
So, just to piggyback off that, a lot of research that we've done either would talk about other specified sexual dysfunction or other specified disruptive impulsive control disorder. And I broke them out, but underneath of them is just saying pretty much the same thing, that this category applies if all the other things and the other diagnoses in that section of the DSM do not qualify. So the DSM has classified over 7 sexual dysfunctions, and to be diagnosed with a sexual dysfunction, the symptoms must be present for at least 6 months, caused significant distress, and cannot be caused exclusively by non-sexual mental disorder, significant relationship distress, medical illness, or medication. So the DSM-5 provides diagnostic criteria for 4 sexual dysfunctions that are specific to biological males. So individuals who are born with male genitalia. So the first one is the delayed ejaculation. It's delayed ejaculation, infrequent or absent ejaculation in at least 75% of partnered sexual activity occasions. In the previous DSM, this sexual dysfunction was referred to as male orgasmic disorder. According to the current DSM, erectile disorder is diagnosed when a male has 1, significant difficulty getting an erection, 2, difficulty maintaining erection, or 3, decrease in how rigid the erection is during 75 to 100% of sexual activity encounters. Male hyperactive sexual desire disorder is the lack of recurrent decrease in sexual thoughts, fantasies, and desire for sexual activities. It is in the responsibility of the diagnosing clinician to determine that desire is not only perceived as low in comparison to the desire of one's partner. So they would need to determine that. And the last one for males is the premature or early ejaculation. So this is diagnosed when ejaculation occurs within 1 minute following vaginal penetration and before the person wishes it on at least 75% of partnered sexual activities occasion. So it's not something that they are wanting to happen. For the female sexual dysfunctions, there are 3 in the DSM-5 to biological females again. So individuals born with female genitalia. So female orgasmic disorder is a delay in frequency of or absence of an orgasm, or a reduced intensity of orgasmic sensation during 75 to 100% of sexual activity encounters. There is also the female sexual interest / arousal disorder. This is absent or reduced sexual interest / arousal. This is determined by meeting 3 or more of the following criteria. So 1, reduced or absent interest in sexual activities. 2, reduced or absent sexual thoughts or fantasies. 3, reduced or no initiation of sexual activity or not responding to partner's initiation. And then 4, reduced or absent excitement or pleasure during 75 to 100% of sexual activities events. 5, reduced or absent interest or arousal in the context of sexual cues. Or 6, reduced or absent genital or non-genital sensations during 75 to 100% of sexual activity events. As with the male hyperactive sexual desire disorder, these symptoms must not only be a desire discrepancy between the partners. So, the diagnosis of female sexual interest or arousal disorder is a combination of females' hyperactive desire disorder and females' arousal disorder from the DSM. Finally, the DSM 5 characterize how do you say that? Genitopelvic pain / penetration disorder as constant or repetitive difficulties with 1. Vaginal penetration during intercourse, 2. Vaginal or pelvic pain during penetration, 3. Significant fear or anxiety about vaginal or pelvic pain, and 4. Tensing of pelvic floor muscles during penetration attempts. So this disorder is a combination of the diagnostic criteria of previous disorders from the previous DSM, sorry. And then for the disruptive impulse control and conduct disorders, so basic characteristics of these disorders that fall within the category of disruptive impulsive control and conduct disorders are aggressive and self-destructive behaviors, destruction of property, conflicts with authoritarian figures, disregard for personal or social norms, and persistent outbursts of anger disproportionate to the situation. Behaviors within the category are behaviors that infringe upon or violate the rights of others or vary significantly from the norms of society. It is important to understand that nearly all children and adolescents experience symptoms of defiance, disobedience, and breaking the rules at some point in their childhood development. In disruptive impulsive control and conduct disorders, the behaviors are much more frequent, pervasive, and result in impairment to the individual's lives. These behaviors also significantly exceed the normative behaviors for their culture, age, and gender. So a couple that I had listed were oppositional defiant disorder, intermittent explosive disorder, and kleptomania. So in this case, it would be in relation to sexual control and desire.
So some symptoms that are continued for sexual addiction are chronic obsessive sexual thoughts and fantasies, compulsive relations with multiple partners, including strangers, lying to cover behaviors, a preoccupation with having sex even when it interferes with daily life, productivity, work performance, inability to stop or control the behaviors, putting oneself or others in danger due to sexual behaviors, feeling remorse or guilt after sex, and experiencing other negative personal or professional consequences.
So when talking about sex addiction in teens, it's similar to adults. And teens with sex addiction have compulsive behavior, and an adolescent spends large amounts of time engaging in sexual-related activities to a point where they neglect social, academic, and family responsibilities. There is a loss of control over one's behavior. So again, you just have to, as a clinician or professional, weigh the difference between teen curiosity, I guess, and an actual addiction. So I put on here, adults or caregivers in the teen's life may see the following behavior: obsessive thoughts about sex that disrupt functioning at school, home, or at work, inability to refrain from viewing pornography or engaging in sexual behavior, and avoiding time with friends or other typical teen activity and instead spend time on the computer or having sexual encounters. Keeps doing
Loneliness. So many sex addicts have an overwhelming feeling of loneliness and fear of being abandoned. Because of this, these individuals may jump from relationship to relationship or stay in relationships that are unhealthy. When alone, these individuals might feel empty, incomplete, or depressed. Along with that, these individuals might over-sexualize feelings of guilt, loneliness, or fear.
We also thought it was important to talk about partner boundaries. So it's important to note that if you or someone you love suffer from sex addiction, you might not have healthy boundaries. If your partner suffers from this, you may also feel annihilated, isolated, depressed, angry, humiliated, and many more emotions. And you may consider seeking treatment for yourself or as a partner with your partner.
So there are risks that come with this addiction, both for men and women. So some of those risks include HIV and AIDS and other STDs, unwanted pregnancies, potential decline in personal relationships, potential decline in work productivity, psychological effects including shame, guilt, inadequacy, emotional distress, and many more.
Other potential outcomes include failing marriage, missing work, we mentioned this so many times, decreased work activity and loss of employment, and ruining friendships, health problems, and financial problems.
So Carnes pointed out that there's some classifications and behaviors that follow individuals with sex addiction. Some of these behaviors follow under sexual fantasy, planning for sexual liaison, and more important than this activity is more important than actually having sex itself. This plays a seductive role. There's the second one, seductive role sex, which causes a lot of excitement, kind of risky, where the individual is chasing another individual often. There's voyeuristic sex, which is the focus on visual stimulation, including watching erotica. Exhibitionist sex, which is attracting attention to the body or sexual parts for arousal. Paying for sex. This obviously is very straightforward, where an individual may pay a sex worker, which creates excitement for that individual. There's trading sex, which is based on arousal that's attached to gaining control of others through sexual activity. Intrusive sex, which is created through excitement that follows the violation of boundaries without resulting repercussions. There's anonymous sex, sex that involves no obligations or commitments of any sort. Pain exchange sex, which is arousal that occurs through specific sex scripts or humiliation and shame. Exploitive sex, which is arousal that's based on having sex with vulnerable individuals. And then, of course, masturbation, where individuals can also become addicted to excessive masturbation.
So we put a slide in here just saying what could cause sex addiction. I feel like a lot of people always like, what causes this, what causes that? But it's unknown and probably has to do with a lot of different things. So research among the LGBTQ community, Native American population, deaf community have found that there are associated risks that may cause sex addiction. But that's not to say that if you're in those populations that you are going to have that addiction. And some of those risks, some of those associated risks include neglect, abuse, could be sexual abuse from your childhood, and lack of education. So those are other areas that could lead to sex addiction.
There are threatening types of sex addiction. Sex addictions can involve threatening behavior, which could involve children, adolescents, or non-consensual partners. This could include rape, exploitation, pedophilia, sexual sadism, sexual machismo, and frotteurism. Rape is known as forcing another person to have sexual intercourse with the offender against their will. Exploitation, the action of making use and benefiting from resources. So in this case, using an individual to gain sexual pleasure. Pedophilia is a psychiatric disorder in which an adult or adolescent experiences a primary sexual attraction to prepubescent children. Sexual sadism disorder is a condition of experiencing sexual arousal in response to the extreme pain, suffering, or humiliation of others. Sexual machismo disorder is the condition of experiencing reoccurring or intense sexual arousal in response to enduring moderate or extreme pain, suffering, or humiliation. And then finally, Freuderism is a paraphilic interest in rubbing usually one's pelvic area or erect penis against a non-consenting person for sexual pleasure, and it may involve touching any part of the body, including the genital area.
Takes so long to actually load. Okay, so comorbidity and co-addiction. Individuals with sex addiction can have additional mental health diagnosis as well as having polyaddiction, including substance use addiction, gambling addiction, depression, anxiety, PTSD, and so on. This may vary from client to client, but it's important to understand and know additional diagnosis so that a professional can work through symptoms of each and that treatment and medication plans can be accurate and the most helpful for the client. Clients may also experience suicidal ideation or self-harm. It may be beneficial to obtain knowledge of physical disabilities as well, as they might have a medication for those or symptoms that are related to that. And also, when talking about medication, definitely medication and also including vitamin intakes. Overall, it is helpful to understand the client's health holistically and to be confident as a professional so you can move forward with them. Okay, let's see if I can do this while we're here. This is a movie I watched a couple years ago and I thought it was interesting.
Is that a sobriety medallion?
I've been in recovery for 5 years.
For what?
Sex addiction.
What?
I'm sorry, I know I should have told you. I've been meaning to tell you for a long time.
Is that even a thing? Is that like, isn't that something that guys just say as an excuse when they get caught cheating?
No, it's not an excuse, it's a disease.
I don't understand why you didn't just tell me. I don't understand. I told you right away that I had had cancer. Why didn't you?
It's different. There's stigma.
There's no stigma to cancer?
Cancer gets you sympathy. My thing gets you judgment. Okay, do you remember when on our first date when you said to me that you couldn't date another addict and you wouldn't date another addict? So there I am. I'm having a great time with a woman that I really like, and I'm thinking, oh fuck, I don't want this to be over before it even gets to be started. Phoebe, I'm sorry. I should have told you sooner. I know I should have, but I'm telling you now, and I promise you from now on it'll be full disclosure, okay?
I need some time to just think about all this.
Okay, I understand.
So, as that video was showing, there is associated stigma that comes with sex addiction. there are some differences between men and women. Um, Something that was pointed out that individuals might lie for more sex or lie about having multiple partners due to shame. Like the video suggested, there's a lot of judgment, so that's a negative stigma that comes with sex addiction. There can be positive stigma as well associated with power and control, or men and women viewing themselves as very appealing, very sexually attractive. This can sometimes, maybe it is a negative and a positive stigma at the same time, but this could possibly boost someone's ego or self esteem. For men, there's a lot of objectification of women. I pointed out that this is almost societally approved of or normalized. This isn't for all cultures, but among the United States, that seems to be what happens. Women, which, this for this addiction, it's not really discussed as much or pointed out. It's kind of like alcoholism in the past. You know, we didn't necessarily believe that women could be addicted to alcohol, and this is kind of the same thing that we're just now getting to, where we see that women are also addicted to sex as well. It's been pointed out that about 1/3 of sex addicts are women, and individuals are often looking for more individual emotional connections to repair their past trauma through finding control and power in their relationships when they're having sexual activity.
I don't know why it does that. Every time I try to move to the next one, it skips over it. So assessments that I found, obviously several self-assessments that could be different depending on state, location, whatever. And then same with the self-report of behavior, so like clinical interviews, intake, stuff like that, just having them say their behaviors, their patterns. So that is definitely used as an assessment for this diagnosis. I also found the sexual addiction screening test. So this is developed in cooperation with hospitals, treatment programs, private therapists, and community groups. And when I was searching assessments, this is the main one that I found. It's pretty long and has a bunch of yes/no questions. And then the other one is the PATHOS questionnaire. But I didn't really find a lot of information about that one.
So there's a lot of treatment options for individuals that are addicted to sex. There's individual therapy sessions, which can be 60-minute or 30-minute therapy sessions where they sit with a licensed mental health practitioner, specifically focusing on the individual's sexually uncontrolled behavior and any associated mental health issues. There's cognitive behavior therapy, which is a treatment option that specifically centers on thoughts, emotions, and behaviors and functions to alter negative thought processes to positive ones. Group therapy. This treatment option is facilitated by licensed therapists to produce a treatment designed to make detrimental actions and negative thoughts into positive and pro-social ones. There's marriage counseling. This is ideal for both the sex addict and the spouse or partner. The counseling can improve their trust and communication skills. It can also help them forge a healthy sexual relationship. There are 12-step recovery programs as well that have been really popular, also used for Alcoholics Anonymous, and has been adapted by Sex Addicts Anonymous. This is a group-based treatment model where the individual is helped in making them willing to live an addiction-free life through complete surrender to a higher power. And then there's also dual diagnosis rehabilitation. This treatment option is ideal for those who have sexual addiction issues and is an accompanying mental health condition. Both conditions are treated simultaneously, and rehabilitation centers are also, out there and an option for treatment as well.
So for cultural considerations, I definitely need to think about individuals with a physical and cognitive disability. This would also go into stigma, just how they live, if they're in group homes or residential facilities, and how that would be considered. Also, men versus women considerations. Nakusa kind of touched on that. Definitely their sexual identity, and definitely the differences across ethnic and racial groups, where they're located, their financial situation and socioeconomic status, in general, their access to care in all of the following areas, and treatment planning. Didn't put on here, but like religious aspects, especially sex before marriage or outside of marriage, if that's happening with this addiction. So definitely consider those. Obviously, it's going to depend on the client and how they experience their own culture. So I can't sit up here and generalize for each of these, but especially since even for sexual identity, there's so many different identities that they could identify as. So it would look different for each client, and definitely, have a good intake and interview to be able to understand your client holistically and what part of their culture is important to them.
Medication intervention. So medications cannot treat sex addiction, but medications can be used to treat co-occurring disorders such as anxiety, depression, PTSD. It's important to have an up-to-date information on your client's medication as well as drug use to account for symptoms and other side effects that may come up. So as we know, comorbidity is really common among sex addiction, and so this is something to keep track of and point out with your client if they're changing any medications or if this needs to be something that you talk about with them.
So resources for the individual with a sex addiction, I found the National Helpline. I'm pretty sure I did see a texting option on there as well. Like Nakusa mentioned before, Sex Addiction Anonymous, sexaddicts.com is another one I found. It was pretty intensive, and it can provide you with DVDs and videos, books and workshops, and support groups for both the individual and the family members to be able to understand what sex addiction is and help them work through that. And then there's sex addiction treatment centers. I'm sure there are plenty more, but this is just what I found during research. There could also be specific resources based on the client's age, gender, race, etc. So keep that in mind if that is important for your client when seeking treatment.
As mental health counselors and or VRCs, it's important to have an open mind when working with clients that have a sexual addiction. Don't add to the stigma or discriminate against them. They already deal with that on an everyday basis, more than likely. Have an understanding of the disorder and how it may present. Understand appropriate resources that you could refer the client to. Seek supervision if it's needed and if you feel as though you don't know where you need to go with the client. Have an understanding of personal and societal factors that may impact a person with this disorder and their treatment, and build a strong working alliance so that clients feel more comfortable sharing information with you. And I'd also like to point out that sometimes even other professionals don't know the answer, and it might be important to just ask your client up front and be very gracious and respectful about it, but sometimes just asking questions is the most important thing you can do. So once again, thank you for listening to our presentation.
Did you want to do it?
Oh, yeah.